It turns out the single most frequent surgical procedure performed in the United States today happens in the maternity ward. Cesarean deliveries account for 1 in every 3 births across the country. That rate nearly triples the safety threshold set by the World Health Organization, which recommends a target between 10 and 15%. Millions of low-risk women, childbirth in America has shifted from a biological process into an aggressive surgical event. That surgery carries severe physical consequences. Compared to a standard vaginal delivery, patients undergoing a C-section face much higher rates of hemorrhage, persistent pain, and rehospitalization. Those risks compound. If a mother requires a primary C-section, her likelihood of severe maternal morbidity and complications escalates in every subsequent pregnancy. To figure out why these risky surgeries are overused, researchers analyzed a massive dataset covering over 13 million low-risk hospital deliveries in the U.S. The study identifies invisible, systemic financial incentives as the primary driver behind this surge in surgical volume. This starts with the math of hospital billing. To find the profit per procedure, you take the total charges billed by the facility and subtract the actual costs of wages, supplies, and utilities. When we look at those profits across U.S. hospitals, a stark divide emerges. For the lowest profit quartile of hospitals, the average margin sits at roughly $4,969 per surgery. But in the highest profit quartile, hospitals make a staggering $26,129 per C-section. That is a 5.3-fold increase in profit for the exact same procedure. That gap remains firmly in place, even after adjusting for a patient's age, their insurance type, and any pre-existing medical complications. The data reveals a direct correlation. Simply walking through the doors of a high-profit hospital significantly increases a low-risk woman's odds of undergoing surgery. A mother's likelihood of facing major abdominal surgery is inextricably tied to the math of the hospital's billing department. The researchers used a counterfactual model to test the impact of these incentives. They asked, what would happen if all low-risk women delivered at those low-profit hospitals instead? The study estimated that 146,752 fewer cesarean deliveries would have been performed. That represents over 146,000 individual women who underwent a major, potentially risky abdominal surgery that they did not actually need. This excess volume generated massive revenue for the hospitals, while passing the physical recovery and surgical risks directly onto the patients. Removing the allure of high financial returns would eliminate over 6% of the nation's C-sections, demonstrating how much of the current rate is dictated by the bottom line. Systemic incentives rarely manifest as individual doctors chasing personal bonuses at the bedside. Instead, high organizational profit targets establish an upstream culture where administrative policies, staffing levels, and quality programs are built around the bottom line. This administrative environment subtly, yet consistently, nudges the entire medical staff toward a surgical intervention over natural birth. The modern hospital ecosystem operates as a business, engineered to optimize financial returns, regardless of individual physician intent. Some states have attempted to fix this through bundled payments, a system where a hospital receives a single flat fee for a birth, regardless of the method, to remove this surgical incentive. But that solution remains an outlier in a U.S. fee-for-service model that still dictates the majority of healthcare economics. The fee-for-service system commodifies maternal health, treating natural births as low yield and surgical births as highly lucrative. Until financial incentives are decoupled from childbirth, the medical decision to perform a C-section remains compromised by the business of medicine. The American medical system is currently generating massive revenue by passing unnecessary, lifelong surgical risks directly onto women's bodies.